Good evening. Thank you, Dr. Henry, and thank you, um, dear esteemed members of the Physician Club, for this opportunity to speak in front of you. So, as Dr. Renoy mentioned, today we'll be discussing about aplastic anemia predominantly, and maybe I'll also, from a physician's perspective, you will be also interested in how to approach cytopenias. So, if you aplastic anemia term, I'll come to a little later, but in general, we group everything under this terminology now, BMFS. That is the new terminology, that is bone marrow failure syndromes. So we know it is not a single disease. You have inherited and acquired. So it's a group of disorders now. And we know the pivotal problem is the stem cell defect. And it can be congenital or acquired. And you can have all three lines affected in a bone marrow failure, or you could have even one line affected, or maybe two lines affected. So it can be a congenital and acquired also. So these are the kind of split between inherited and acquired. For example, if you take the red cells, you have Diamond-Blackfan anemia in pediatric age group, which is a congenital one. In acquired, you would see similar pure red cell aplasia. And in child, you would see the congenital neutropenias, different varieties. And towards adolescent and young adult, you may actually find somebody coming to you with a cyclical neutropenia, which is a bit not so severe disorder, but you may occasionally find them in a complete blood count that neutrophils are low. Thrombocytopenia usually gets diagnosed as ITP mostly, but some of the so-called ITPs are not really ITPs. And in pediatric age group, you have other congenital abnormalities like absent radii with megakaryocytic thrombocytopenia. And in adults, you could have a bone marrow failure affecting predominantly megakaryocytes and presenting in severe thrombocytopenia. That's called megakaryocytic thrombocytopenia. Now, for the classic presentation is pancytopenia. And then in pediatric age group, you have the flagship disease is, of course, Fanconi anemia. And then some of us must have also seen dyskeratosis congenita. But there's a lot of other disorders which are not so common, but still we may have to keep in the differential diagnosis. In adult, aplastic anemia is very classical, but you could have people with myelodysplastic syndrome as well as paroxysmal nocturnal hemoglobinuria, otherwise abbreviated as PNH, presenting with pancytopenia. So in short, we say that pancytopenia is not aplastic anemia, and pancytopenia will have differential diagnosis. So the classic teaching is that if you have a pancytopenia, then you differentiate as pancytopenia with a hypocellular marrow or pancytopenia with cellular marrow. And of course, the aplastic anemia comes under those with hypocellular marrow. It is also important to remember that sometimes acute leukemias also present with hypocellular marrow and pancytopenia. And sometimes lymphomas like hairy cell leukemia, hypoplastic acute myeloid leukemia, all these can present with hypocellular marrow. The other thing is, you find pancytopenia, and when you do a bone marrow, you find the marrow as very cellular. And this is not very uncommon, I must tell you. And the differentials start with myelodysplastic syndromes, hypersplenism, of course, and then you have myelofibrosis and bone marrow infiltrative diseases and autoimmune diseases, B12 deficiency, sometimes other infections, and then sarcoidosis, and um, substance abuse, and tuberculosis. All this can result in a hypercellular marrow and then pancytopenia. So, and then we come to aplastic anemia, and how does aplastic anemia occur? And a lot of implicated agents are there in aplastic anemia. You say, benzene is one of the very, very frequently quoted culprit in causing aplastic anemia, especially industrial exposure to benzene and irradiation. One of the classic way where we see irradiation is resulting in aplastic anemia is when you give pelvic irradiation and some cancers, and then you develop aplastic anemia. We often say chloramphenicol and other anti-epileptics, but the evidence is not very strong for any of these drugs to cause aplastic anemia. On the contrary, we often see that aplastic anemia happens after a viral infection, especially a hepatitis, because you often see very high transaminitis running up to the aplastic anemia. And this is often very difficult to get this. It's often seronegative, where the classical A, B, and C are usually negative. We can pick up with the modern investigations Epstein-Barr virus and parvovirus, and these are two things which we often see resulting in pancytopenia. And of course, then we have pregnancy where you find cytopenias, and then some other disorders like thymoma, particularly resulting in pure red cell aplasia. So, yeah. So if you take the history of aplastic anemia, it starts with this great man, Paul Ehrlich, and he discovered many things first, and he actually described a young woman with bleeding and fever, and the marrow was strikingly hypocellular. And Dr. Anatoly Shafard actually named aplastic anemia. So the clinical features are of all the three cytopenias: anemia, bleeding, or infections. And the physical examination is distinct by remarkable absence of organomegalies or lymphadenopathies. And again, if you look at the peripheral smear, it is distinct by, you don't see many cells there at all. You don't see any cells at all, or very few cells. And but even if you see these much things, you can suspect aplastic anemia, but you need to do a bone marrow, and you need to actually do a bone marrow biopsy and not an aspirate. An aspirate may not pick up the diagnosis of aplastic anemia. This is because the aspirate can actually, this needle can go to a cellular site and give us a wrong impression of a cellular marrow. So if you look at the marrow, this is the normal marrow. You can see the fat lobules here, and then all the hematopoietic cells are there. Whereas in an aplastic marrow, this is how it looks like, and it almost looks like replaced with fat. You hardly find any hematopoietic cells there. So we can classify the severity of aplastic anemia. This is a very old classification, 1976. It's about 50 years old, but it still followed. And you need actually 2 out of 3 severity markers, that neutrophils less than 500, platelets less than 20, and reticulocytes less than 20. And if you have these criteria and the neutrophils are further less than 200, then you call it very severe aplastic anemia. And a non-severe aplastic anemia is where you don't fulfill this criteria. Why do we need this classification? I think it's very important to classify aplastic anemia early on, because the treatment is remarkably different between non-severe and severe. And the prognosis is remarkably poor in very severe aplastic anemia. So this classification still has stood the test of time. So this is a in I think 6 years back in New England Journal of Medicine. This was an article by Neil Young, who has done a lot of work in aplastic anemia, and this was a beautiful figure which depicts largely our ignorance about this subject. That so you see here aplastic anemia here. We know that it's a multi-lineage. So this is single lineage here, and this is multi-lineage here. And here they say, if you have a T cell immunity defect and a B cell immunity defect, go up on the y-axis it's B cell and down on the y-axis is T cell. And so aplastic anemia is a pancytopenia and maybe T cell defect as there and a bit of B cell and quite a bit of overlap between aplastic and myelodysplastic syndrome, an overlap between PNH and an overlap between HLH also. And of course, in between you see diseases like LGL, and there you have the pure red cell aplasia coming here, immune thrombocytopenia and hemolytic anemia. So here you see a lot of B cells, and then down here you see a lot of T cell defects. So fairly a lot of overlap between these differentials. So we need to be a bit careful. So when when we look at the pathophysiology of the disease, you can see that the cellular marrow is replaced by fat cells. And if you have to document that the stem cells are defective, you can use a marker called CD34, and then that CD34 will be markedly reduced in the bone marrow. And contrary to the popular belief, because of the very low levels of the CD stem cells, these patients hardly respond to colony stimulating factor. So in addition to the stem cells, the bone marrow stroma, which is harboring the stem cells, that is also found to be defective in aplastic anemia. So we could have, as I mentioned earlier, how does this attack on stem cells occur? You could have a direct attack on the stem cells with the viruses and radiation and chemicals, or it could be an immune mediated. And these things, once affected, then triggers some immune mechanism and then results in depletion of stem cells. So that's a diagram actually depicting a lot of T cell mechanisms, T cell activation, differentiation, expansion, and then apoptosis of the hematopoietic stem cells with the T cells. So it is said between B cells and T cells, if you had to choose which is the more dangerous in aplastic anemia, it is the T cells. It's a T cell activation which is more. So it's an autoimmune disease. There is no doubt that aplastic anemia is an autoimmune disease, but it's predominantly mediated by T cells. I mean, no matter what is the insult, the immune system is triggered and immune system is activated. But if all aplastic, the question is if all aplastic anemias are similar and with the same pathophysiology, because you can see many of the patients with aplastic anemia, you're treating with immunosuppressive therapy, which is the gold standard treatment, but everybody doesn't get cured. Why everybody doesn't get respond to the immune suppressive therapy? This is interesting because recently there's a lot of research gone into this subject called telomere biology. Telomeres are at the end of the chromosomes. These are kind of protective tips at the double-stranded DNA end. Actually, they protect the rest of the chromosome from dying. And so what happens sometimes is telomeres shorten. The telomeres shortening is said to have a role in the pathophysiology of some of the patients with aplastic anemia, especially the mutations in the TERT and TERC, which is usually found in the disease dyskeratosis congenita. So, but it's not only in dyskeratosis congenita. Now there is a terminology called telomeropathies. So telomeropathies may be inherited. in families, and you may find other members of the family having a similar, they may have pulmonary fibrosis, they may have a liver cirrhosis, they may have macrocytic anemia. So everybody in the family may not have the same disease, but anybody in the family with pulmonary fibrosis, or say liver fibrosis or cirrhosis or a macrocytic anemia, I think that family history may help us in assuming that this may be a telomeropathy. And usually the telomeropathies are not very severe as the immune-mediated aplastic anemia. So that's one of the other different way by which we could think about. Nowadays, there are tests to find out the telomere length, and there are a lot of studies have happened outside India and also within India, and which have looked at the length of telomeres in the peripheral blood leukocytes, and which especially in the donors also to see that if the telomeres are shortening, then it affects the overall survival and also the prognosis in bone marrow transplantation. Because if you have the donors with low telomeres and the patient with aplastic anemia is going for a bone marrow transplantation, those with low telomeres, the recipients don't really do well. So telomere biology is very interesting. It's still in the nascent stage, and a lot of things are being studied on this. So again, if you were to put everything in one figure, this is how it would look like. There's a physical damage or a chemical damage. There's a majority going with immune destruction, and then there is also somebody with constitutional genetic defect also. So this is the telomeropathy kind of thing. So telomeropathies generally respond to sex hormones like danazol and stanozolol, and majority of the patients with immune destruction present do respond to immunosuppressive therapy, and some of those with physical damage responds to hematopoietic growth factors. I'll come to that in a little more detail. So this is the importance of recognizing constitutional or inherited aplastic anemia, because because they don't respond to immunosuppressive therapy. And for the constitutional or inherited aplastic anemia, bone marrow transplantation is the only curative therapy. So these are some of the constitutional marrow failure syndromes. So telomere diseases, Fanconi anemia, GATA deficiency, CTLA4 deficiency, etc. So I'm not going into the details of each of this, but maybe Fanconi is very common and relatively. So it was described by a Swiss pediatrician, and then he described 3 brothers with pancytopenia, and they have a lot of common things. You have short stature, hyperpigmentation of face, oral mucosa, distinct skin abnormalities, and elfin-like facies, you can see here. Often skeletal abnormalities and renal abnormalities. You can see the thumb abnormalities is quite very common in Fanconi, as well as you can see here the horseshoe kidney. So how do you actually diagnose? Because all the patients with Fanconi may not present with constitution. 50% of them may not have the constitutional symptoms or sign, these abnormalities. So we could do a blood test that's called the stress cytogenetics, and it can be done using mitomycin or diepoxybutane. And this will show increased sensitivity, and you can see here the triradial formation of the chromosomes. So because in Fanconi the DNA repair mechanism is defective, you will find increased triradial formation with mitomycin stress or diepoxybutane stress. This test is called stress cytogenetics. Again, this is a very old test, but it's still being followed as a screening test for Fanconi. Again, the second condition of telomeropathy is dyskeratosis congenita, where you have nail dystrophy, skin pigmentation, leukoplakia. and then bone marrow failure syndrome. The disc keratosis congenita is not so severe sometimes, and the patients live into the adulthood. I mean, I had one of the patients diagnosed at 58 years of age, disc keratosis congenita. So sometimes they're so, very benign kind of thing, but you diagnose them a bit later into the adulthood. So as physicians, some of you might actually see disc keratosis congenita presenting to you for the first time. So, it's always important to take a few histories, like what the patient has taken any drugs toxic to the bone marrow. Sometimes acute lymphoblastic leukemia can present with pancytopenia, and they may have had steroid intake due to some reason. So it may be a masked phenomenon. So it's very important to ask the question of steroids. And when you do the physical examination, look for the facial dysmorphism. Examine the patients for skeletal abnormalities, skin changes, and etc. So the history of surgeries in childhood, sometimes, the other inherited bone marrow failure syndromes may have, other associated skeletal defects, and so it's important to ask that question. And hematological illness in the family, and early onset of liver or lung problems, again for telomeropathies. So you have a lot of differential diagnosis for aplastic anemia. You have a bone marrow with a hypoplastic myelodysplastic syndrome. It is one of the differential diagnoses. So all hypoplastic marrows are not always aplastic, and there are certain ways by which we distinguish this, but I will not go into that. Then you have PNH. PNH sometimes may have a increased lactate dehydrogenase. That may be the clue from the peripheral blood picture. And then you have inherited bone marrow failure syndromes, or TLGL, or hypoplastic acute leukemia, or a condition called as refractory cytopenia of the childhood. So much so about the differential diagnosis. Now actually coming to the treatment. You have supportive treatments and definitive treatments. The supportive treatments include transfusions and prompt treatment of infection. Definitive treatment have the specific measures to reconstitute the hematopoiesis. And these include the gold standard, of course, is bone marrow / stem cell transplantation. But in the absence of that, you continue with immunosuppression, which includes thymocyte or lymphocyte globulins and cyclosporine and combination drugs and TPO agonists like eltrombopag and romiplastim and androgens. So, in the West, it's a different picture. Actually, you see all these graphs from the West. This is the CIBMTR, or the bone marrow transplant registry from North America. You see that after bone marrow transplantation in pediatrics, it's excellent results. More than 90% children survive, and more than 80% adults survive. But it's a different thing that we see in India because we see a large lag time between the diagnosis and bone marrow transplant. The patients are often multiply transfused, and a lot of infections are there. So bone marrow transplants, if you see that may not be the actual picture in India. We have higher rejection rates, higher morbidity during transplants, higher mortality rates, and long-term survival. So these are some of the problems, not only in India, but larger in the developing countries. But again, some of the data published from India actually show that it's not all that bad. So you still see, adults and children with at least 60 to 70% survival, even in high-risk patients, which is not really bad. Even those poor-risk patients who are multiply transfused, we are able to salvage 2/3 of them. So when do we actually do transplant and when do we not do transplant? So usually up to 50 years of age. Earlier it was 40 years of age, we can do transplant. And if less than 50 years of age, if you don't have a matched sibling, or if you are not having a severe aplastic anemia, then you can go for non-transplant. That mainly it is anti-thymocyte globulin based therapy. And this anti-thymocyte globulin is usually say, produced from rabbits or horses, but they are injected from with the thymus, and thymus is collected from during cardiac surgery, and then this is injected into the animal, and then they produce a serum antibodies, and this is purified, and this formulation is there. So you have a horse formulations and rabbit formulations, and what is mostly used in aplastic anemia is the horse formulation or equine formulation. And we used to have Adgam, which is the Pfizer's product, which was the manufacturer in Switzerland, and now it's after COVID, it's no longer available. So we use now Thymogam, which is the Bharat Serum product, which is available in India now. So either of this product, you use 40 milligram per kg per day for 4 days, and patient is usually admitted, and steroids are given, because one of the unique toxicities is serum sickness, and usually it can cause immediate allergy. So you give an intradermal allergic skin testing, and then sometimes you have this is a serum sickness. Usually between 10 to 14 days you may have this, so you cover the patient with steroids for during this time. So there are a lot of data on the response. Roughly 60 to 70% people respond to the ATG, and you often add cyclosporine. It's a combination of ATG plus cyclosporine, and then cyclosporine is given at 5 milligram per kg per day for 3 to 6 months initially. Of course, cyclosporine can have toxicities like nephrotoxicity, hypertension, gum hypertrophy, etc. And then we have androgens, and usually it's given in mild and moderate aplastic anemias. And the response is not very good. It's about 30%. And what happens for some strange reason is aplastic anemia is a lot of patients come from lower socioeconomic background also. So there was a study done in Thailand which actually looked at the in epidemiology for aplastic anemia. So quality of life, quality of living, a lot of aspects of exposure to pesticides, non-bottled water, all of these were implicated in that study to cause aplastic anemia. So again, coming back to the role of androgens, it is one of the agents that we can give for aplastic anemia for relatively economically downward patients. We can use both danazol and stanozolol. Stanozolol is mostly used in men and danazol in women. So these are the new treatments, that is eltrombopag and romiplostim. These are the thrombopoietin receptor agonists, and so this a lot of new studies have come. This is an NEJM paper. Actually, it was approved for ITP at 50 milligrams eltrombopag, and now it is being used for aplastic anemia at 150 milligrams per day dose. And initially, the proof of principle came from the single agent study, and then they combined it with the immunosuppressive agents, that ATG plus cyclosporine. So now it is called ACE therapy, ATG, cyclosporine, eltrombopag. And now this is the standard of care. And then of course, you start eltrombopag from day one, and the response rate has gone up to 70 to 80% with this combination. So here, in this slide actually summarizes how we treat aplastic anemia in children and adult. So in children, you can see immunosuppressive therapy plus or minus eltrombopag. In adult, definitely adding eltrombopag has proven benefit. And if you have an HLA match sibling and an adult is less than 40 or 50 years of age, you go for allogenic transplantation. But if you go for immunosuppressive therapy, and in 3 to 6 months, if you have a treatment failure for young children, then you go for alternate transplant. In adults, of course, the other option is to go for a second immunosuppressive therapy. These patients can evolve into MDS because this is a clonal evolution can occur because of the treatment also, and also of the disease. So they can evolve into MDS, AML, or PNH. So it's important to keep following up this patient even after the therapy. For the Fanconi anemia, I think it's allogenic transplantation. That's an inherited condition, so it's not a acquired condition. So you cannot have immunosuppressive therapy for inherited bone marrow failure syndromes. It is allogenic stem cell transplantation, and this is the curative in majority of patients, at least in 75%. But in the conditioning regimen, you have to actually modify the doses, because you saw that figure, no? The chromosomes are breaking. There is no DNA repair. So if you give doses like busulfan, cyclophosphamide in full doses, they will break up and have very, very bad mucositis. So all the drug doses, especially the cytotoxic drugs, are dose modified in Fanconi anemia. And if you are not able to transplant a patient with Fanconi anemia, you could still give them a quality of life by giving androgens and sometimes steroids. But these are not, of course, curative. Another important thing when you counsel a patient with Fanconi anemia for transplant is that it can have other malignancies like squamous cell carcinoma, all those malignancies can still occur even after hematopoietic stem cell transplant. Hematopoietic stem cell transplantation will cure only the bone marrow. So you could still have, other malignancies, and that needs to be counseled for the patient. So I think we now come to the conclusion, and I think the most important thing I would like to emphasize is that the diagnosis often goes wrong, Fanconi anemia, because we find pancytopenia and we try to equate it to aplastic anemia, which we should deter from, and we often make the diagnosis from bone marrow aspirate. We need a neat bone marrow biopsy reported by an expert pathologist to say that it is indeed aplastic anemia and not hypoplastic leukemia or hypoplastic MDS or anything else. Second important thing is that it is not only important to diagnose aplastic anemia, it is also important to distinguish whether it is inherited or acquired, because up to age of 40, you could have inherited bone marrow failure syndromes presenting, and some of them may not have the constitutional features. So nowadays there is next generation sequencing where you could use to identify some of the mutations, and so we often do that to distinguish inherited from acquired aplastic anemia. Stem cell transplant is the treatment of choice with more than 75% chance of cure. And if there is no matched donor available, or if you are an older patient, immunosuppressive therapy with 3 drugs is also reasonable with adults with aplastic anemia. And for inherited bone marrow transplant, the transplant is the only option for cure, but doses need to be changed. With that, I thank all of you for your patient attention. We'll be happy to take any questions. Thank you.